Hello everybody, my name is Miikka Vikkula. Here shortly my conflicts of interest. Today I will talk about Gorham-Stout disease. It is sometimes called vanishing bone disease or also idiopathic massive osteolysis or progressive massive osteolysis. It is due to gradual bone loss, osteolysis, which is caused by abnormal growth of lymphatic vessels. These thin-walled lymphatic vessels expand, they dilate and multiply, and this leads to the breakdown of bone, called bone resorption. Most commonly, we see bones such as ribs, spine and pelvis, skull bones, the collarbone or clavicle, shoulder blades, jaws, but also other bones that are affected. The signs and symptoms vary widely among patients with Gorham-Stout disease, from very mild to very severe. They depend on the location of the lesions and on the bones and soft tissues that are affected. A common early sign is pain and swelling near the affected region without any clear cause. It can also be a spontaneous fracture of a bone after a minor trauma to that area. Other symptoms include breathing difficulties, chest pain, weight loss, and chylothorax, which is accumulation of lymphatic fluid, that is chyle, that leaks into and accumulates in the chest, and that can lead to infections and respiratory distress. Lymphatic anomalies actually are a spectrum of lesions and diseases, varying from the cystic lymphatic malformations to complex or complicated lymphatic anomalies, those that we are discussing in this session. The Gorham-Stout disease is one of the CLAs, and the diagnosis in between these entities is not always easy. Also, the CCLAs may be part of the GLA, GSD, KLA spectrum. We have studied tissue samples that we have collected from 18 Gorham-Stout disease patients, and for 6 of those, we were able to perform whole exome sequencing analysis. The whole exome sequencing analysis allowed us to identify a somatic change in one of the tissues that was present at 28% frequency, seen as those little green squares on the images on the right. We had also performed a cancer panel for the same tissue, and there also we saw in the same gene, at 23% variant allele frequency level, the same somatic change. The change was identified in the KRAS gene. It is one of the hotspot mutations in this gene, causing an amino acid substitution, glycine, at position 12 to valine. The patient in whom this variant was identified had osteolytic lesions and intraosseous lymphatic malformations on the right clavicle, humerus, radius, and cubitus, right femur, tibia, and on a vertebra. The parents were asymptomatic. They did not have Gorham-Stout disease, which is classic. It is not an inherited disease. Pathologic humeral fractures occurred at 6 and 8 years of age. In adulthood, chronic ascites with intestinal lymphangiectasias that cause executive enteropathy at the age of 33 years. She also had progressive necrosis of the right wrist and the forearm, which led to transhumeral amputation at the age of 36 years. She was treated with several medications, including interferon alpha-2a, thalidomide, sunitinib, and finally also with sirolimus, but none of them really had an important effect. She unfortunately passed away because she developed a fulminant sepsis at the age of 37 years. In A and B, you can see macroscopic pictures of the humerus after the amputation. You can appreciate how the bone structure has been destroyed by the invading lymphatic vessels, also the cortical part in picture A. The histological images below, from C to G, demonstrate that the structures identified have immunohistochemical markers of lymphatic vessels. Moreover, much of the bone marrow was replaced by adipotic tissue. While we have been working on our series of Gorham-Stout disease patients, a case report was published from Japan by Nozawa et al. They also identified a somatic KRAS mutation, not the same one, but glutamine 61 arginine change. The variant allele frequency was lower, but clear, 2.25%. The patient experienced massive osteolysis and bone infiltration in the skull, and also a mass occupying space in the right nasal cavity. Based on the increasing knowledge on etiopathogenesis of various lymphatic anomalies, we have come up with this phenotype-genotype-based classification algorithm. As we can see, lymphodemas are on the left and the lymphatic malformations on the right. And for many of these groups, actually genes are now known as the causes of the phenotypes. For the left side, they are mostly germline changes, whereas those on the right, they are mostly somatic changes. We have the PIK3CA gene, but then also in the complex or complicated lymphatic anomalies, the NRAS-KRAS-ARAF series of genes. It is of medical interest to realize that all the entities on the right side have a hyperplasia of their lymphatic system as a common factor, in addition to the fact that the causative changes are increased activity of signaling due to activating somatic mutations. If we shortly sum up the functions of those proteins, we can see that we have two major signaling pathways, the Tie2 PI3 kinase AKT-mTOR pathway and the RAS-RAF-MAP kinase pathway. The gene identified to be mutated in Gorham-Stout disease, KRAS, is an important member of these signaling pathways. And most, if not all, of the mutations identified in the various vascular anomalies activate these pathways, just like in oncogenesis. That is why drugs that have been developed to treat cancers may now be useful also for vascular anomalies. Among those drugs, we can identify rapamycin, miranzertib, ponatinib, and alpelisib, but also trametinib or selumetinib and vemurafenib. Based on these discoveries and the animal model that Mike Dellinger will be discussing later in this congress, Gorham-Stout disease seems to also be a rasopathy, at least in some patients. Therefore, MEK inhibitors may be beneficial to these patients. I would like to thank all the members of my laboratory, and especially Nassim and Pascal, who were important in the Gorham-Stout disease project, in addition to the clinical multidisciplinary group and Professor Laurence Boon in the middle, where all the clinical samples are collected. I would also like to thank all our collaborators, especially Mike Dellinger, with whom the mouse model was developed, as well as all the funding agencies without whom we would not be able to do all these studies. I thank you for your attention.